Okay, I'm back. There's some issue with the YouTube broadcasting, so that's a delay. So if you see the lymphoma, छोड़ दीजिए जितना हो टाइम ही नहीं है. So if you see the lymphoma classification, it starts with way back in 1956. Now it is a 2020. So it is a basically starts with a Rappaport classification. Now we are following the WHO classification. If you see, as the technology improves, like initially there is only morphology, like what we are seeing over the slide, and the clinical parameters. Then follow there's only few entities. So as the newer techniques, cytogenetics, FIS, microarray, and next generation sequencing, so now there are more than 30 or 40 entities if you go to each in B and T cell lymphomas. So how they classify? So basically it is the, if you know the normal ontogeny of the B and T cells, these lymphomas, they arises from each and every steps. The one kind of lymphoma arises. So let's take an example of B cells. It arises in the marrow, like pro B cells, then followed by pre B cells, then the immature B cells. These all three altogether called the blastic phase. Then followed by it comes to the naive B cell, then which come out from the marrow and comes to the lymph node, to the mantle zone, where it has a naive B cells. If you see the markers, initially they are 20 negative, then surface immunoglobulin negative, then they acquire the surface immunoglobulin, then CD20, initially CD19 present throughout the cells, throughout the maturation, but CD20 initial phase it's absent, then again appear, then when it mature to plasma cell again disappears. Then another marker is PAX5, which is a nuclear transcription factor which present throughout the maturation. So if you ask somebody with the pan B cell marker, you can say it is a PAX5. CD20 definitely is a B cell marker. It is a both diagnostic and predictive value, but unfortunately it is not a pan B cell marker. It is in the both extreme stage, it is absent. So from the naive B cells is present in the mantle zone that goes inside the germinal center or the follicles. It is the, then it goes to the centrocyte, centroblast, then comes to the post-germinal center, then memory cell, plasmablast, and plasma cells. The extreme is positive for CD138. So similarly in the T cell, so where it appears, how it matures, it is basically the thymus, the central organ, where it the whole maturation happens. It is starts with the marrow. From marrow it comes in the same immature state, it comes directly to the further development in the thymus. Thymus, there is a two stage, basically beta selection phase, then the repeater selection phase. You can say double negative in the beta selection phase, or there is like a cortex and medulla. You can say cortical phase or medullary phase. In the cortical phase there are two, like you can remember double negative, double positive, and single positive. What does mean by double negative? In terms of CD4 and CD8. So initially the CD3 appears, basically cytoplasmic CD3 followed by surface CD3. Then if you see other markers like CD4, CD8, everybody knows there are two major kinds of T cells, like CD4 and CD8 T cells. Among the CD4 cells, there are many other kinds of cells arise, like CD4 helper, TH1 type, TH2 type, Treg, then TH17. There are 4 or 5 types of cells. Okay. So initially these CD3 positive cells are both negative or double negative phase. Then the TCR gene rearrangement occurs. Then it comes positive for double positive stage, or DP or CD4-8 both positive. From there they divide into in that stage they are in medulla. Then they divide into 4 and 8, one single positive, one helper, one cytotoxic. So if you see both ontogeny and B and T, if they arises from the earlier precursor, they are called blasts. If they are mature, they are called mature B cells lymphoma or mature T cells lymphomas. So this is the how the WHO classification basically based on the immature cells. Lymphomas arises from the precursor cells, lymphomas arises from the mature cells. If you see the B cell neoplasm, so how many entities? There are 42 types of lymphomas of B cell neoplasm. There are 50 new entities added a couple of years back. So day by day, as though we know their genetic, their newer genomic genetic signatures, their mutational profiles, and and their clinical behavior. So we divide into different entities. So this, apart from 42 entities, how can we further divide? We can further divide into two groups, like aggressive lymphomas, indolent. If first, precursor and mature. So precursor, those are all blast. So just forget about, we are not discussing today about the blast. We will discuss in the when your lymph node chapter came. Today basically CLPD, lymphoproliferative, those are basically indolent lymphomas. You can call a low grade lymphomas. People earlier used to call low grade lymphomas, now people used to call it indolent lymphomas. So among these, what are the indolent lymphomas? For all practical purpose, for undergraduate point of view, you can remember 4 or 5 lymphomas which are low grade or indolent, like follicular lymphoma, CLL/SLL, mantle cell lymphoma, marginal zone lymphoma, or variety you can call a lymphoplasmacytic lymphoma. There are many other lymphomas, but which are very rare, and you rarely encounter those lymphomas. If you come here, then follicular, then SLL, mantle, marginal, LPL, then the immunoproliferative small intestinal upset. These 5 lymphomas at least every undergraduate should know, and they can present as a, sometimes may present as a leukemic features, or may present as a lymph nodal mass. So how the T cell lymphomas, we are not discussing too much today regarding, but the classification is the same: premature cells and mature cells. Among the matures, it could be leukemic, could be nodal, could be cutaneous, or maybe extranodal. In lymph node chapter, I will discuss more. So how they classify lymphomas, how, what are the basis of this classification, their markers, as I told in my made about 2 or 3 years slide back. Like there is all their ontogeny, how they derive, how they goes. Like precursor lymphoma, if you see this, where the pointer here, this pointer will be visible, this pointer, okay. Okay, so this is a precursor neoplasm, so it is a lymphoblastic lymphoma. Then they come the naive B cell, which come to germinal center in the mantle zone. So mantle zone cells are basically naive cells. Naive means they are not exposed to the antigen till now. So once they any lymphoma which arises from this precursor, they are lymphoblastic lymphoma. Any lymphoma which arises from the mantle zone is the mantle zone lymphoma. Then comes the germinal center. Then germinal center, there is a follicular lymphoma. These are the Burkitt, diffuse large B cell. We'll discuss later. Those are aggressive lymphomas. Then in the outer outer part, there is a marginal zone. So it arises from the marginal zone. It is marginal zone lymphoma. Clear? So today I am going to discuss 4 basic lymphomas. Like lymphomas arises from the follicles or germinal center, or the follicular lymphoma. Then comes the mantle zone, mantle cell lymphoma. Then comes the marginal zone lymphoma. Lymphoplasmacytic also originate from here. Then come the CLL. People used to call this is a little bit controversial, CLL, but usually cause it's a post germinal center only. It's not the germinal center cells. So how lymphoma biology, it's indolent versus aggressive. What is the indolent means? Incurable. Aggressive, or you can say it is very clinical course, but somehow they are curable. Aggressive lymphomas has a short natural history and very rapid cellular proliferation. But the interesting is many of the aggressive B cell lymphoma, they respond to treatment, and this indolent very long course. They will say or like it's a 2 years, like a patient will come complain there's a mass for last 1 year or 2 years, it is now slowly progressing. Now they will come when there is obstruction or there's some disease related symptoms rather than. But aggressive lymphomas, if it is saying, patient is saying it is a only 1 month history, 2 month history, very unlikely is indolent lymphomas. Okay. So earlier people used to call low grade, high grade. Now they are no more using these terms. They are better than clinical point of view, aggressive lymphomas and indolent lymphomas. So how they present? Almost all. As general, they present as a tendral lymphadenopathy. 1/3 of NHL present symptom related to the organ involvement. Okay. Signs and symptom: normal hematopoiesis by tumor cells or the marrow, fever because of the cytokine. So there is a called B symptom: fever, night sweat, and lymphadenopathy. These are classically called B symptoms. So what clinical feature you should know when you are seeing a patient of a lymphoma, or before classifying you require at least age, because there are few lymphomas which occur in older age, like follicular lymphoma, which are older age. There one entity called pediatric follicular, very rare. Blastic neoplasms, the mostly B lymphoblastic lymphoma, more common in children than the generalized or localized. So there is a general lymphadenopathy or localized lymphadenopathy. Duration, how much duration? That you can guess whether it's aggressive or indolent. Then I told B symptoms: fever, night sweat, and weight loss. So what are the investigation you basically required for a lymphoma? It is at the clinical, as I told, it is very crucial is the clinical history. Then the complete blood count. There is one enzyme which can helpful is LDH. Many lymphomas, because of turnover, there is increase in the LDH. Then peripheral smear, flow cytometry, fine needle aspiration, biopsy. Then you need the molecular workup as whatever the tissue available. Then for staging, you need the PET scan, CT, and X-ray. So the flow cytometry, Dr. Ganesh will discuss in details regarding the flow cytometry. Okay, so how you can come out. Then another very crucial is the what called clonality. Clonality means whether you can the lymphocytes, they are exposed to this what called these antigens. So when there is antigen exposure, if there is a polyclonal, so it is basically normal. If it is a tumor, as you all know, they arises from a single clone. So you can say whether it is a clonal population or whether it is a polyclonal population. How can you say? In case of by molecular methods, by also IHC. IHC, you can say whether kappa or lambda, which light chain is restricted. In case of that can be done by flow cytometry or IHC, or you can do a molecular like a fragment immunoglobulin gene rearrangement or T cell receptor gene rearrangement. So staging, it is the Ann Arbor staging based upon that stage 1, stage 2, stage 3, stage 4. Then A and B, presence of B or presence of B symptom. So like how the stage 1 is a single group of lymph node. Stage 2, same side of the diaphragm but do two different groups of the lymph node. Stage 3, both side of the diaphragm. And stage 4 is the disseminated disease. Then one more you should know the IPI score, which is very important for prognostication. There are 5 factors like age, LDH, ECOG performance status, clinical stage, and extranodal disease. So now come to normal lymph node. How they look like? You can see this is a normal lymph node which has a capsule, and they formed by subcapsular sinuses. Then the cortex. In the cortex you find the follicles. In the medulla you find the medullary cords. So what are the what inside a lymph node? There is a B zone, there is a T. T basically paracortical, B is the basically the follicular areas, right? So if the follicle could be sinusoidal, marginal. Okay, so all the germinal center of follicular B cell, and like here these are the B zone, and in between these are the T zone. Okay, then the sinuses, macrophages, and dendritic cells. So how they look like, you can see it could be nodular. In the gross you can find there's many nodules, or maybe simply a fishy place appearance, like fish place homogeneous enlargement of the lymph node. And sometimes you find the necrosis in between. These black areas are the necrosis and hemorrhages. So in a normal reactive, so how to define whether when you see a lymph node, whether reactive or lymphoma, then only you can go ahead. So normally you find these follicles and germinal intact capsule. Then the cortex, there are many follicles and there are variable size, one small follicle, one large follicle. Then the intact mantle zones, then the medulla. Okay, so there is architecture. If you do FNAC, you see all range of cells, starting from centrocyte, centroblast, tingible body macrophages. So you find all population of cells. So this is a normal follicle. It is, remember, it's not a circle or whatever the germinal center. It is always elliptical, or you can say like egg-like. So with a polarization. Okay, it is a mantle zone. This is the germinal center. This is a secondary germinal center. Okay. So now this is the picture. You can say this is the germinal center. This is the mantle zone. This is the marginal zone. So any lymphoma, marginal zone lymphoma, mantle zone, mantle cell lymphoma. From the germinal center, the follicular lymphoma. I am talking about only about the indolent lymphomas. Okay, so if you do normal immunohistochemistry, CD20 positive in the follicles and CD3 in the intrafollicular area. So you can see this intrafollicular area is T zones and this is the B zones. Then the one factor is the BCL2, which is absent in the germinal center but present in the T cells. So it's the normal. Okay, so and CD23 throughout you can find this follicular dendritic cell measure very well circumscribed in nature. And cyclin D1 normally it is not present, it is usually absent. Ki6 polarization, because you find a dark zone and light zone. where high proliferation, there you find a high Ki, and proliferative index, a low proliferative index. So this is the then.
Sir,
Yes.
sir, lecture is going too fast. We are not able to catch up with what's like
Okay. Okay. Okay.
what.
So you can find few T cells inside what call in a follicle. Okay. So you can find these are the T follicular helper cells, right? So normally I told this is a follicle, means this is a B cell follicle. Okay. So there are you can see few CD3 positive cell inside the follicle. It is called T follicular cells. Okay. This normal structure I will repeat once again in the lymph node right now, because I am going to touch about few lymphomas. So that's why it's a pre-introduction. Don't worry, I will repeat all these in your lymph node lecture also. So one in case of a normal, I told you, you find a you can find a cortex where you find these kind of follicles, and the medulla where the medullary cords. So once there is a lymphoma, the architecture is lost. You don't find this cortex and medulla. What you can find, either you find this kind of follicle back to back, or you find this kind of diffuse area. Okay, so if find a diffuse area of in a follicular pattern, so what are the lymphomas? It could be follicular, could be mantle cell lymphoma, could be small lymphocytic lymphoma. Usually follicular lymphomas shows follicular pattern, but other lymphoma can also present with a follicular pattern. Okay, so how we work up? So we do, these are the normal immunohistochemistry marker you have to remember, which we do for the classification of the lymphomas, right? So in case of diffuse, again the same differential diagnosis comes, like CLL, SLL, mantle, follicular, marginal. Why I am showing this? Never confuse. If you see only a follicle, it is only follicular lymphoma. Other lymphoma can also present as a follicular. Similarly, if it is a diffuse, it doesn't mean it is a CLL, SLL or mantle. Follicular lymphoma can also present as a diffuse pattern. So the you have to do proper immunophenotyping. What does it mean by immunophenotyping? You have to do these CD markers like CD3, 25, 23, and their genetic features. So for a classification of a lymphoma, you need morphology, you need immunophenotyping, like what kind of markers present over the surface or the nucleus, and what kind of genetic abnormality is there, right? You need all three in combine to classify a lymphoma. So first comes around whether it is a reactive or a lymphoma or atypical hyperplasia. When we are saying it is atypical, any particular feature, there is not a single feature where you see, you call this is a lymphoma, right? If it is a follicular pattern, so it is a, you have to take into account many things, like whether it is a generalized lymphadenopathy or it is a localized lymphadenopathy, whether it is an older patient, whether it is a young patient, right? So taking into all factors, immunophenotype, then only you decide whether it is a lymphoma or not. So what factor in a lymph node you will see whether call it is a lymphoma? Loss of architecture. I told you it is a like cortex medulla. You are not able to identify cortex medulla. Then densely packed follicle. Very well. You find 40 or 50 follicle. All are monomorphic. There. In the reactive, I show you one small follicle, one large follicle. Here you find densely packed follicle. Then absence of mantle zone and loss of polarization. I told you dark zone, light zone. You don't find. You will not find all these. Then the extracapsular extension, lymphocytes present outside the capsules. So these are subtle features where think of whether it could be a lymphoma. Like you see here, it's a normal lymph node. You find a cortex, medulla, follicle. Then there is a dark zone. There's a mantle zone. If you see this lymph node, there is a extrafollicular extension. There's a capsule outside the capsule. Then you find many follicles, back-to-back follicles, the densely packed follicles. Okay, so this is a higher power. You can see there's a capsule, but the lymphocytes are coming outside the capsules also, right? Here there is a back-to-back follicles. So these are factors. One is loss of architecture. You don't find cortex and medulla. Then if loss of mantle zone, right? Then the extracapsular extension. So these are the subtle features where yes, probably I am dealing with a lymphoma, not a reactive node. Okay, so you can see here this is a CD20, this is a CD3, but all follicles have a normal size. Okay, so one factor for reactive versus follicular lymphoma, BCL2 is a very important immunostat which indicate 14-18 translocations. Basically, it is a protein which never expressed in the germinal center. If it is expressed in the germinal center, means it is a follicular lymphoma. Then the CD10 is the normal distribution, like these follicles are positive for CD10 and BCL6. These are the markers which indicates the lymphoma originate from the germinal center. So again the same pictures. Now this is a case of a follicular lymphoma. So how CD20 positive, 3 negative, BCL6 positive, CD10 positive, and CD23 is the normal pattern, CD23 negative. Okay, so so this is a, and if you do the Ki67, you find it is a loss, like the polarization is loss in case of Ki67. So this is a case of a follicular lymphoma. So what is follicular lymphoma? Follicular lymphoma is a neoplasm composed of follicular center or germinal center B cells which at least partially follicular pattern. So there are many types of follicular lymphoma subtypes, like in situ neoplasia, duodenal, diffuse variant, testicular variant. Okay, so it's the one of the most common lymphoma in the adulthood, like it's comprise around the 20%. If you see all lymphomas, so most common is the diffuse large B cell lymphoma, then comes this follicular lymphoma. The highest incidence reported in the western countries, then the our Asian subcontinents. So predominantly adult, mostly in the 6th decades, male to female ratio is to 1 is to 1.7, so little bit of female predominance. And one more thing is highest the environmental exposure to pesticides and herbicides. Nowadays it is extensively used. If there are many literature shown, if those persons which are exposed to these herbicides and pesticides, they show circulating these cells which carry this T1418 translocation. This means these are the precursor cells and which in future may transform to a lymphoma. Okay, so predominantly involves lymph nodes, but also includes spleen, marrow, peripheral blood. How they present? Present with painless lymphadenopathy and waxing and in clinical course. Sometimes the patient will come 1 year, kabhi bada ho raha hai, kabhi chota ho raha hai. Okay, sometimes they increase in size, sometimes they decrease in size. And if you do marrow, 30 to 50% case they may be involved. Okay, sometimes in 30% case they get spontaneous regression also. Survival is usually good, median survival is more than 10 years. Sometimes they may also go to a aggressive lymphomas. So how they grade? There are three grading, like grade 1, grade 2, grade 3, based upon how many number of centroblasts present inside a follicles. 0 to 5, 6 to 15, and more than 15. This is inside a follicle. See, these are the centroblast. Few centroblast, more than 15 centroblast, less. So grade 1, grade 2, grade 3. So grade 3 A, B hota hai. B is the very worst situation. You have to treat like a aggressive lymphoma. So it could be follicular, it could be diffuse. So if it is less than 25% of follicles, it is called a diffuse pattern. So what is the genetic signature? It is the translocation of 1418, which causes the IGH and BCL2 gene. Okay, so that's why you are finding BCL2 protein in the neoplastic cells. Okay, so this is the hallmark 1418 translocation. These are the other things like 1P, 6Q, 10Q. These are other abnormality which may be associated. Okay, so mostly some patients survive more than 20 years. That's why indolent, 10 to 15%. Within 3 years of diagnosis, those which are transformed to aggressive lymphomas. Okay, so next comes the in situ neoplasia, like this is a precursor. You find inside whole follicle only single follicle BCL2 positive, like you can see here. So in future it may progress to a neoplasia, like carcinoma in situ. So this is in situ follicular neoplasia. Duodenal type, it is mostly occur in the duodenum and very indolent. If you just biopsy it, cut it, not required at all, but it shows classical features. Okay, you can see in the endoscopy find a node, CD10 positive, BCL2 positive. Clear? So this is the case. You can see CD20, CD3, then the BCL6 and CD10 positive, BCL2 positive. So in few cases it may be BCL2 negative, but very rarely it can show BCL2 negativity. Clear? So now this is another case. You can see again extranodal and this follicle, monomorphic follicle back to back size. So now I invite Dr. Ganesh to carry on the next most common lymphoma, the CLL, SLL, like which is basically you can find in the peripheral blood. Then once cover the CL blood part, then I will again back and discuss the other lymphomas. Dr. Ganesh, to you.
Thank you, Dr. Soumya. So you gave a good overall, and I will continue from here. Though I have a few common slides. Let's see, I can skip them if possible. So good afternoon all. So thank you, Dr. Samiranjan. Dr. Samiranjan talked about the lymph node architecture. What are the normal cells which are present in the lymph node? What are the structure in the lymph node? And he talked about the difference between leukemia, lymphoma, and also what are the lymphomas which can arise based on the specific architecture of the lymph node. So I have a few common slides which overlap with Dr. Soumya's. I quickly rush through it, and I will concentrate on the most common type of lymphoproliferative disorder, that is CLL, SLL. So starting with the terminologies, Dr. Soumya had already explained this. Just to put it in a brief, chronic lymphoproliferative disorders is a term which is it is a broad group of disorders under which there are different types of entities. So sometimes the terminology is chronic lymphoproliferative disorders, indolent lymphoid neoplasms, low-grade lymphomas, small cell lymphomas. These are interchangeably used. The common feature among this group of disorders is that clinically speaking, they have a slow clinical behavior, meaning they are not very aggressive disorders. They progress, take long time to progress. And under microscopy, the cells are generally small to medium sized compared to high grade lymphomas or large cell lymphomas, where the cells are much larger. Again, this is a broad oversimplification. There are many entities within it, like mantle cell lymphoma, which can have blastoid appearance sometimes. But overall, this is the general idea. And it's better to use the term indolent lymphoid neoplasms to denote this group of disorders. And again, high-grade lymphoid neoplasms and large cell lymphomas, they are put together under one loose basket. Again, it's better to classify the entity, like the important entity being a diffuse large B-cell lymphoma. And also, we need to emphasize on the term leukemia and lymphoma. Leukemia is the presence of this malignant cells in the peripheral blood marrow, whereas if it's present as a lymph nodal mass or as a mass lesion, it's lymphoma. But one important thing to understand is that one type of presentation can spill over to other type of presentation, or vice versa. Like disease can start off as a leukemia and then it can present with lymph nodal masses, or it can start off with a lymphoma and then it can progress on to involvement of peripheral blood and bone marrow that can result in a leukemic presentation. Or sometimes some patients can have both of this at the single point of time. For example, in the case of CLL, so CLL is chronic lymphocytic leukemia. It is basically a leukemia, so the disease is expected to be present in the blood and bone marrow. But sometimes these patients can also have small lymph nodes, so they can have both lymphomatous and a leukemic present. So that's why we use the term CLL/SLL. SLL meaning small lymphocytic lymphoma. So small lymphocytic lymphoma is the same disease which is presenting as a lymph nodal enlargement or a lymphoma, whereas the same disease, same type of cells, same morphology, same type of immunophenotype, when they're present in the blood and in the bone marrow, we use the term leukemia. This is the simplified chart to show the cell of origin. In the last acute leukemia class, we learned that the acute leukemias or precursor neoplasms are from stem cell, whereas the mature lymphoid neoplasms, under which the CLPD, chronic lymphoproliferative disorders, indolent lymphomas come, they arise from the mature lymphocytes. And Dr. Soumya said this earlier. So we need to understand the normal maturation of B lymphocytes. It starts from the lymphoid progenitor cell to become a naive cell, and then germinal central cell, and then finally plasma cell. So the cell of origin of lymphoma also mirrors or recapitulates the normal lymphoid maturation. So broadly, again, the classification has been spoken about. It's B or T and NK neoplasms. You have to understand that these are mature lymphomas in comparison to precursor lymphoid neoplasms. These are called acute lymphoblastic leukemias. So when you see blasts and they are immature type arising from a stem cell, that is a acute lymphoblastic leukemia or an ALL. It's again the WHO 2006 recent classification. Dr. Soumya had shown this. It enumerates numerous entities, but for simplicity and to have a basic understanding, we will mainly study the common lymphoid neoplasms under the category of indolent lymphomas. We will concentrate mainly on CLL, SLL, that is chronic lymphocytic leukemia, small lymphocytic lymphoma in this lecture. If time permits, we can just touch upon other entities, mantle and margin zone lymphomas. Dr. Soumya had already described about the features of follicular lymphoma and how to differentiate it from reactive follicular hyperplasia. So before going into CLL per se, we want to know what are the different categories under which we can study this lymphoproliferative disorders. So it helps in the classification also. So each type of lymphoproliferative disorder has a characteristic clinical presentation. For example, follicular lymphoma, it's a disease of old age, and CLL, it presents in the middle to old age, and CLL has a very long course, meaning the patient can live for many years and sometimes decades even with the disease. And the pathogenesis depends on the regulation of B cells, either they are anti-apoptotic genes which are involved or pro-proliferation genes which are involved. We'll come to that when you study each individual's entity separately. And each type of this lymphoma or leukemia has a characteristic morphology. For example, the CLL cells, they look like normal mature lymphoid cells with clumped chromatin and small sized cells. And they have a lot of smudge cells in the background in the peripheral bed. So that morphology helps in the identification of these subtypes. Follicular cells, when you see in the, you looked at, you were told about the lymph node architecture, lymph node morphology, but when they are present in the peripheral bed, when they have a leukemic presentation, you can see the centroblasts and centrocytes. So you can have this cleaved morphology within the lymphocytes. And again, one of the important tests we do to classify is the immunophenotype. So what is meant by immunophenotype? So phenotyping is typing, immuno is immunology. So what is immunology? It's presence of a protein. So what type of protein we are looking for? We are looking for surface protein. So surface CD markers like CD19, CD20, CD5, CD23, CD10, etc. So each leukemia or each lymphoma has a characteristic immunophenotype, and that is repeated in each individual. So when you take CLL has a characteristic group of immunophenotype. You take follicular lymphoma, you have it as a characteristic immunophenotype. So it's important to identify the immunophenotype to subclassify or characterize the disease. So we'll touch upon that in the end. What are the markers we do, and then how we classify them. So this is flow cytometry is one type of test or technique where we can do this immunophenotype. So flow cytometry is, for flow cytometry you need a liquid sample. So what are the liquid samples available? You can have peripheral blood, you can have bone marrow. So these two are liquid samples. So when you have liquid samples, you can perform flow cytometry. Flow cytometry needs a flowing type of sample, so it needs liquid sample. Whereas immunohistochemistry is typically done in solid samples. So what are solid samples? The lymph node biopsies. So biopsies from the lymph node as well as bone marrow biopsies. So both of these give you a tissue, a solid tissue. So the solid tissue, you can put it in and process it in a paraffin block and then do immunohistochemistry. So again, in immunohistochemistry, the technique is, the basic idea is same. In that you study the CD markers either in the surface or sometimes you can see the immunological markers within the nucleus or cytoplasm. So based on the type of markers present, you can classify the lymphoma or leukemia. So mainly the lymphoma classification is done based on clinical features, morphology of the cell in the blood or in the lymph node or lymph node structure and immunophenotype, either by flow cytometry or immunohistochemistry. Other tests are not done in all cases. Other investigations are only done in selective cases when you want to further subclassify it and or prognosticate the disease. They are useful in very specific entities where they give you the diagnosis. This include karyotyping or cytogenetics, where you look at the chromosome. Then there is fish testing, fluorescent in situ hybridization. We use molecular probes which are fluorescent to look for specific regions in the chromosome. You can study the altered chromosomal structure also, including deletions, translocations, etc. And you can do molecular genetic tests in which you look at the genetic structure. It can help in diagnosis of certain lymphomas like lymphoplasmacytic lymphoma, where you see a MYD88 mutation or BRAF mutations in other harrisol leukemias. So these are done in specific type of lymphomas and leukemias. Coming to treatment, again, we won't talk about it in detail. So treatment consists of combination chemotherapies, meaning you use a group of 3 or 4 chemotherapeutic drugs to treat this. These are done over a period of time for many months, so 6 months, 8 months, in cycles, meaning one cycle will last for 1 month, 1.5 months, etc. Nowadays, newer molecules are available which target specific pathways in the cell, specific for each type of lymphoma. So mainly the classification depends on this clinical presentation, microscopy of the lymph node, morphology of the peripheral blood bone marrow sample, and immunophenotyping. Other techniques we use as and when needed. Staging, we use Ann Arbor staging. Dr. Soumya explained that in detail. So the staging is from 1 to 4. 1 is very early stage, 4 is late stage. As you can understand, when the disease progresses to late stage, the prognosis is poor. In the early stages, the prognosis is much better. And again, it's subdivided into A and B. B is the presence of symptoms. One of the 3 symptoms. What are the symptoms? Fever, night sweats, or body weight loss. Again, B symptoms indicate the disease has progressed much. So in flow cytometry or in immunohistochemistry, we use certain markers to classify this. So what are these markers and how do we use them? So we use markers to classify whether it is B or T cell. So B cell, what are the B cell markers? 19, 20, 10, etc. And the T and K cell markers are CD3, 7, 8, etc. And then we go ahead and subclassify the B. So we establish that it is a it's a B cell B cell neoplasm. It's showing 19 and 20 positive. Then we use other markers like CD5, CD10, etc. to subclassify this. And again, kappa lambda is used to demonstrate monoclonality. We use other markers as and when needed, like CD11C is useful in harrisol leukemias, CD23 in CLL, CD56, 57 in natural killer cell neoplasms, etc. So coming to the main or most common type of leukemia among the indolent group of lymphoid neoplasms, it is chronic lymphocytic leukemia. It comes under the category of CLL, SLL. When it's presenting as a lymph nodal or lymphoma type of presentation, we call the same disease as small lymphocytic lymphoma. So CLL is characterized by accumulation of mature lymphocytes. In the blood, bone marrow, lymph nodes, and spleen. So all these are lymphoreticular structures and hematological involvement. And the lymphocytes are mature appearing lymphocytes, meaning they appear like the lymphocytes seen in a normal peripheral, but the numbers is multifold increased. They have certain differences from a mature lymphocyte. That's why you use the term mature appearing. In that, the chromatin is somewhat condensed. It has a soccer ball chromatin. We'll see 1 or 2 pictures soon. And the B lymphocytes are CD5 positive. Normally, you don't expect CD5 positivity in a normal mature B lymphocyte. A very small proportion can be positive, but in general, most of the normal B lymphocytes are negative for CD5. In CLL, the characteristic finding is the presence of the CD5 positivity in the B cells. So it is one of the most common lymphoma, leukemia, which has CD5 positivity, other being mantle cell lymphoma. It's a disease of older patients. The highest incidence occurs more than 50 years. Most of the cases are preceded by something called MBL. So what is MBL? Monoclonal B-cell lymphocytosis. So monoclonal B-cell lymphocytosis is a precursor lesion. So we studied in the morning class on plasma cell neoplasms that plasma cell neoplasm also has a precursor lesion. So what was the precursor lesion for plasma cell myeloma? It was MGUS, so monoclonal gammopathy of undetermined significance. So it starts off as MGUS and then it progresses to smoldering myeloma and then multiple myeloma. So similarly in CLL, in almost all the cases, it starts off as something as MBL, monoclonal B-cell lymphocytosis. We'll come to that. It is a precursor lesion which occurs before CLL. So over a period of time, over a period of many years, MBL converts into CLL. So this precursor lesion may not be always diagnosed in all patients, just because they are not picked up when the patient doesn't have any symptoms, and then the patient comes to the hospital only when he has symptoms. The exact reason or cause of CLL is unknown. A combination of environmental factors and genetic factors have been proposed, but as such, a single specific consistent factors unknown. So how does this disease behave? What's the pathogenesis of CLL SLL? It is an indolent. So indolent is meaning slow onset and slow growing. So it's a slow growing neoplasm. So even if the tumor is left untreated, even if the leukemia is left untreated, in a large proportion of patients, it goes on for years. So the patient can survive for even years. In a small proportion of patients, of course, the disease becomes aggressive, it causes symptoms. Then again, in that case, you have to treat the patients. In fact, a large proportion of the patients, when they are diagnosed incidentally and they don't have symptoms, they may not be treated at all. You just observe the patient regularly to look for disease progression, and then the patient can be just kept under observation till something changes. So here, there are two main mechanisms of tumor cell production. One is increased proliferation and increased survival. So either the cell proliferates more so that it accumulates, or even if it's not proliferating that much, if the survival of the cell is prolonged, it causes increased tumor survival. So one important feature is BCL2 overexpression or high levels of BCL2 within this CLL SLL cells, which is an anti-apoptotic protein. So this results in increased survival of these cells. Again, another feature is something called a proton tyrosine kinase pathway or BTK pathway. Here, the pathway stimulates downstream signaling pathways for increased cellular proliferation. So the signals gets activated through surface immunoglobulin, which are present on the surface of these B cells, and because of that, they activate the BTK pathway. This is in increased proliferation of these cells. So anti-apoptotic and increased proliferation. So both are involved, but more importantly, it is anti-apoptotic pathways. Clinical findings. So we just discussed that many of the patients may not be asymptomatic at diagnosis. So these patients are diagnosed incidentally, or when they go to the hospital for something else. So a patient can go for dental extraction or some dental problems. They do a blood test, routine blood test on CBC. Suddenly you see an increase in WBCs, leukocytosis and lymphocytosis. And then the patients are diagnosed with that. The patients may go for something, a routine health checkup. And then during the CBC examination, you can see lymphocytosis, and the patients are diagnosed like that. A small proportion of patients present with symptoms, and the most common symptom is fatigue. So fatigue, as you can understand, is mainly because of the anemia, because the cells involve the bone marrow, resulting in reduced normal hematopoiesis. Again, if the patient has a lymphomatous presentation, so involvement of lymph nodes can be enlarged. So Obviously, when the lymph nodes are enlarged, the patient notices that, and then he comes to the hospital, comes to the clinical care facility to get treatment or to get evaluated. Some of the patients can have infections because the T cells in CLL, they are not functionally adequate, so they don't produce the immunoglobulins necessary. So again, that leads to infections. Symptomatic patients can have enlargement of lymph nodes or lymphadenopathy and splenomegaly. Hepatomegaly can be seen, but it's less common than splenomegaly. And sometimes the patients can have infiltration of other structures. Mainly these are lymph nodal structures, example tonsils, mesenteric lymphadenopathy. The patient can have abdominal disturbances, abdominal masses which when evaluated turn out to be lymphadenopathies, and rarely skin infiltration. So when the disease progresses to a very later stage, we'll come to staging of CLL in a bit. We involves the bone marrow. So because of that, the patient can have reduced red blood cell production, resulting in anemia and bleeding, etc. Sometimes there is a hemolytic type of presentation also. The blood lymphocyte count are usually above 5,000 per microliter, and the morphology appears similar to a normal small mature lymphocyte. And you have many of these smudge cells. We'll show you a picture in the next slide. While making a smear, the cells are fragile. So what happens? The cell breaks. So when the cell breaks, the cytoplasm gets stripped off and the nucleus gets smeared over the slide. So that results in smudge cell or basket cell. So after clinical examination, if you look at the peripheral blood morphology, in most of the patients, you can make a diagnosis of CLL. So this is the blood smear of a patient with CLL. So you can see that there are 1, 2, 3, 4, 5, 6 cells, 6 lymphocytes, 6 cells, and almost all of them are lymphocytes. There are no neutrophil cells. So it is lymphocyte predominant blood picture. And you can see the size of the cell, it's almost equivalent to the RBC here. So it's almost the size of the RBC. So it's a small mature lymphocyte. You can see that the chromatin is clumped. So how does it appear clumped? You can see dark and light areas within the nucleus. And sometimes it becomes very prominent, resulting in what is called as a pavement or tile-like chromatin or soccer ball chromatin, where you have this alternate hexagonal light and dark areas. So that is a characteristic feature seen in this CLL cells. Again, you can see a cell here. This is what we call as smudge cell. So this smudge cell is basically the nucleus of this lymphocyte. So the lymphocytes have this fragile cytoplasmic integrity. So when you make a smear, because of pressure, the cytoplasm is stripped away and then the nucleus gets smeared over the cell. So this is characteristic. So the number of smudge cells are very prominent in case of CLL. Though this can be seen with other lymphomas and other leukemias, the number is much higher and characteristically seen in CLL. So this is the lymph node biopsy, just to show the lymph node architecture. Dr. Soumya talked about different types of lymph node architecture, whether it's a diffuse infiltration or a follicular type of nodal type of infiltration, etc. Here in CLL, you can see the diffuse infiltration of the small mature appearing lymphocytes. Sometimes you can have proliferation centers within these lymph nodes. You can sometimes see these atretic follicles in the eggs. Sometimes you might not see that. And in the cells, they are almost similar looking. They are uniform sized cells, small to medium, small cells with clump chromatin. Rarely you can see a large a cell with a prominent nucleolus. These are either prolymphocytes or centroplasts, but these are much less in a typical CLL. So once you have examined the patients, taken the history, and then looked for lymphadenopathy, splenomegaly, and then you did a complete blood count, you saw there is lymphocytosis, and then you made a blood smear, and then you looked under the microscope. So you can do other tests in the case of CLL. So you can do a bone marrow examination. That may not be necessary in all patients, but some patients, when the bone marrow is indicated, it shows increase or infiltration by this mature lymphoid cells. And when you do flow cytometry, you can see dual expression of CD19 and CD5. So normally the B cells express CD19, but CD5 is absent, whereas in CLL, you can have both presence of CD5 and 19. There is monoclonality. So what is monoclonality? So in a normal individual, there is mix of both kappa and lambda light chains. Kappa is slightly higher, lambda is lower, about 2:1 is the rough ratio. So there is a range. Whereas in CLL, it's either kappa or lambda. So you can see only one type of light chain because the neoplasm arises from one single cell. So whatever the cell was producing earlier, whether kappa or lambda, it continues to produce in the whole clone. Immunoglobulin gene rearrangements are present and hypoglobulinemia are common. So it's interesting to note that even though there is increase in B cells, it does not translate to increase in gamma globulins or increase in immunoglobulins. Why is that? Normally when the cells proliferate in a reactive condition, we expect immunoglobulins to be higher. But here, because the cells lose their normal function, it results in reduced production of this, and this can lead to infections. Another feature to remember in a case of CLL is hemolytic anemia. So how do you diagnose hemolytic anemia? With a positive direct Holmes test. So why does this hemolytic anemia occur? So it's because the B cells, they produce immunoglobulins which react against the red blood cells, the body's own red blood cells. So when it reacts against the body's own red blood cells, it results in the hemolysis. So when immunoglobulin goes and binds to the red blood cell, it results in lysis of the red blood cell. This causes autoimmune hemolytic anemia. About 10 to 30% of CLL patients can have anemia because of autoimmune hemolytic anemia. So you can do a Holmes test just to diagnose this. So when you see a lot of lymphocytes in the peripheral blood, when you haven't examined the patient or you don't know the history, there's a list of differential diagnoses you should consider in a given scenario. So lymphocytosis can be present in the blood because of infectious causes or malignant causes. So infectious causes can be bacterial, mainly tuberculosis, other bacterial infections, it's mostly neutrophilia, and also because of different viral infections, especially mononucleosis. And the different types of leukemias and lymphomas can have lymphocytosis in the peripheral blood. Any non-Hodgkin's lymphoma, when it transforms into leukemic phase, it can present as lymphocytosis, follicular lymphoma, mantle, margin zone, CLL. There are certain leukemias which typically present as lymphocytosis, like CLL, cell leukemia, and large granular cell lymphocytic leukemia, etc. So what are the investigations we do in a patients with CLL? So before treatment, we do a set of investigations. One, to establish a diagnosis of lymphoma or leukemia, and then subtype the leukemia or lymphoma, and then know something about the behavior of the disease to know how aggressive it is. So what we call a prognostic testing. So all these tests are done just to diagnose, subtype, and then prognosticate the disease. This starts with basic investigations like a complete blood count. It gives you the hemoglobin level. You can see whether the patient has anemia or not. It gives you the WBC count, so you can know whether the patient has leukocytosis, lymphocytosis, etc., and reduced platelet count, thrombocytopenia, and a peripheral blood smear examination to look at the morphology of the cell. So you can see mature lymphocytes here, and then you see smudge cells in the case of CLL, and reticulocyte count to look for hemolytic anemia is increased. Holmes test to rule out autoimmune hemolytic anemia. Renal or liver function test to understand the basic health condition of the patient to plan for treatment. And you do serum protein electrophoresis. So electrophoresis is a test. Protein electrophoresis is a test to study proteins present in a given sample. In the serum, we look for the serum proteins, mainly albumin, globulins, and the subtype of globulins, mainly gamma globulins, including immunoglobulins. So immunoglobulin levels, we do. One, we establish presence of a monoclonal type of protein, and then we subtype the monoclonal type of protein. Next, we do flow cytometry or immunophenotyping from one of the liquid samples. Either you can do it, flow cytometry can be done from peripheral blood or bone marrow, Or if you have a lymph node biopsy, you can do immunohistochemistry to subtype the type of lymphoma. Certain other investigations like karyotype, cytogenetics, look at the chromosomal structure, FISH, look for any directed chromosomal changes that can help sometimes to diagnose and mainly to decide the therapy. And bone marrow aspiration biopsy can be done for staging of the lymphoma. So when bone marrow is involved, it goes on to stage 4, which means the disease is an aggressive disease. Typically for CLL, we use two types of classifications. One is Roy classification and is a Binet classification. So it's a very simple clinical classification, and which takes just blood counts and organomegaly into account. When you do a staging, it helps you to understand the prognosis of the disease. So in Roy, there are 5 stages, 0 to 4. 0, you can have only lymphocytosis. 4, we have lymphocytosis, thrombocytopenia, and splenomegaly. Whereas the intermediate stages are made based on the presence or absence of lymphadenopathy, splenomegaly, anemia, the level of anemia, etc. So as self-explanatory, the higher the stage, the worse the disease and more aggressive the disease. Binet is slightly simpler classification, but again, the classification is based on the blood counts, mainly hemoglobin and platelet levels, and the extent of involvement of the lymph node. So what does involved area mean? Involved area talks about the lymph nodal region. So if the patient has right, left cervical lymphadenopathy, mesenteric lymphadenopathy, and the patient has inguinal lymphadenopathy, then you can say that the patient has more than 3 lymph nodal areas. So more the lymph nodal areas, what's the higher the classification and what's the behavior of the disease. Again, the presence of hemoglobin, anemia, and thrombocytopenia indicates that the disease has involved the bone marrow. So involvement of bone marrow is a very late, late stage, and it indicates a poorer prognosis. So this shows the stage as well as the survival of the patients. Like for example, Roy stage 0, the patient survival is more than 10 years. The median survival is more than 10 years, meaning at least half of the patients are expected to survive more than 10 years of age. Whereas when the stage is 4, it's higher stage, the median survival is only less than 2 years. What are the markers in the case of CLL to understand poor prognosis of the disease? So advanced Roy or Binet, shorter peripheral lymphocyte doubling time. So what is peripheral lymphocyte doubling time? So when the patient of CLL comes to you, you do put the patient on follow-up. So you ask the patient to come on 3 or 6 monthly visits. And you do a peripheral blood count and lymphocyte count. So for example, the first visit, the lymphocyte count was 1,000, and you look for the time when the lymphocyte counts. At first instance the lymphocyte count was 5,000. You look at the point when the lymphocyte count becomes 10,000. So if that occurs, for example, within 6 months, then it is a very rapidly progressing disease, and then it indicates that the patient needs some treatment. Whereas if the time taken to go from 5,000 to 10,000 is 5 years, then you can understand that the disease progression is slow. In the bone marrow, if the involvement is diffuse, then again it indicates poorer prognosis compared to a nodular infiltration. And the presence of pro-lymphocytes or cleaved cells indicate disease progression. So pro-lymphocytes are larger lymphoid cells which look a little like blasts. They have opened up chromatin, they have prominent nucleoli that indicates aggressive disease. And in cytogenetics or on fish, if there is deletion of 17p, so 17p carries the p53 gene. So when this gene is lost or mutated, then again it indicates poor response to chemotherapy. High beta to microglobulin levels again indicates poorer response. So Richter transformation indicates poorer prognosis. So what is this Richter transformation? This is conversion of CLL, which is a small cell lymphoma or endolytic lymphoma, into a very aggressive lymphoma, like diffuse large B cell lymphoma. So when it becomes a aggressive lymphoma, it's very difficult to treat it, and then the prognosis is poor if not treated. Certain chromosomal abnormalities characteristically occur in the case of CLL. This include trisomy 12, deletion 17p, structural abnormalities of 13, so trisomy 13, 14, 11, etc. So all these abnormalities indicate some genetic change, and these are seen in more than 50% of CLL patients. So we learned so far in this seminar about normal lymph node architecture and the origin of different lymphomas based on the lymph nodal structure, and we learned what is an indolent lymphoma, what is an aggressive lymphoma, and then we understood the difference between leukemia, leukemic type of presentation, or lymphomatous type of presentation, leukemia, lymphoma, and we understood the difference between an acute leukemia and a chronic lymphoproliferative disorder. And we learned about how we diagnose this lymphomas, how clinically they behave, present to you, and they can have a leukemic presentation, they can have a lymph nodal presentation, they have organomegaly, splenomegaly, lymph nodal enlargement, etc. And also we talked about the different tests or laboratory investigations that we do to diagnose this, starting from microscopic examination of the blood, the microscopic examination of the lymph node biopsy, and we learned about how to sub-classify these neoplasms, that is using mainly immunophenotypic techniques like flow cytometry in case of liquid samples, and immunohistochemistry in lymph nodal biopsies, bone marrow biopsies. And then we talked about other ancillary techniques, cytogenetics fish, to sub-classify these disorders. So before moving forward, I'll just show you one table which shows how we will classify B-cell neoplasms based on two important markers in flow cytometry or by immunohistochemistry. So when a suspected lymphoma is there, we try to establish whether it is B or T cell. So we do CD19 and 20 if they are positive. It most likely indicates that it is a B cell basal type of proliferation. And to say that it is a neoplasm, we establish a monoclonality. So you do kappa or lambda. So if it is either kappa or lambda only, then you can say that it is monoclonal. And then we try to subclassify it based on immunophenotypic markers. So these immunophenotypic markers are consistent for particular type of lymphomas. So we use CD5 and 10 to subclassify this mainly in the initial part. So what are the neoplasms which are CD5 positive and CD10 negative? So mainly under this category, the important leukemia is CLL, SLL, so chronic lymphocytic leukemia. It is 5 positive, 10 negative, 20 is positive, but it is dim. Immunoglobulins is positive, but it is dim. CD23 is positive, and FMC7 is negative. Another important category under this is mantle cell lymphoma. Again, it is CD5 positive. Here the cells are little larger in size, and 20 is intermediate to high, bright surface immunoglobulins, bright. CD23 is negative, or even it's positive, it's dim. Again, you can use cytogenetic studies to diagnose this, and cyclin D1 IHC expression to do a diagnosis of mantle cell lymphoma, whereas it is absent in CLL, and translocation 11 protein is characteristic. So there are other less common type of lymphomas, which are CD5 positive and 10 negative. We leave that for now. And under the category of CD10 positive and CD5 negative, important lymphoma is a follicular lymphoma. So it is B-cell2 positive, 43 negative, this lymphoma. There are other lymphomas and leukemias which can be 10 positive and 5 positive, but we won't study that now for simplicity's sake. And what are the lymphomas which are 5 and 10 negative? So marginal zone lymphoma, diffuse large B-cell lymphoma, hairy cell leukemia, they are mainly under the category of indolent lymphomas. It's mainly marginal zone lymphoma and hairy cell leukemia, which is 5 and 10 negative. The other lymphomas can have this phenotype, but that is rare. We leave about that. And again, 5, 10 positive, both positive is also rare. So you have to remember that among the CD5 positive lymphomas, mantle cell lymphoma and CLL/SLL is important. And among CD10 positive, it's follicular lymphoma in indolent, and among the aggressive lymphomas, it's the diffuse large B-cell lymphomas. 5, 10 negative, it is marginal zone lymphoma mainly. Hairy cell leukemia again has a characteristic lymphomatous, characteristic clinical presentation. So think I'll stop here. We'll hand over to Dr. Soumya. He will briefly go through the other common subtypes. And again, you have in the next semester, I think, lectures on reticular endothelial system, including lymphomas and spleen, and then we'll try to cover, the other lymphomas. Go to you, Dr. Soumya.
Thank you, Dr. Ganesh.
Yeah.
So in the previous, my first lecture and Dr. Ganesh, we came to know how to diagnose lymphoma. So what are the morphology difference between lymphoma, leukemia, and how they can present. So if you see among the indolent lymphomas, CLL, which mostly present as a present in the peripheral blood, though other lymphoma like among these 5, follicular, CLL, SLL, mantle, marginal, lymphoplasmacytic. So I'm repeating again and again. If somebody asks what are the low-grade lymphomas, people use commonly, but somehow this terminology no more used. You better to call it indolent lymphomas. There are 5 lymphomas: CLL, SLL, follicular, mantle, marginal, and lymphoplasmacytic lymphomas. So which present more in the blood? It's the CLL, SLL, though other can spill over. So rest 3 mostly present as a lymph nodal mass. Okay. So and this CLL when present as a lymph nodal mass, we call it as a SLL, lymphocytic lymphoma. Then rest are all remain same. Like you may find or may not find in the blood, but pure SLL can also present without absence of blood, right? So there are 2 patterns I described. One is your follicular pattern, one is your diffuse pattern. So all these 5 lymphomas, they can present like this. Follicular mostly present as a follicular, but can be diffuse. Rest 3 mostly present as a diffuse, can also present as a follicular. So if somebody asks you, so in slide, if you see a follicular pattern, okay. So in follicular, if you see in a slide follicular pattern, so mostly it is a follicular, other can be. In the blood, if you see mature lymphocytes, many mature, like more than 5,000, so it is mostly CLL, other may be. Okay. So the rest next 2 we have completed, follicular and CLL. Next comes the mantle cell lymphoma. So as it shown you the picture, it arises from the mantle zone, right? And which type of cells in the mantle zone? It is the naive cells. Like they arises from the marrow, they come directly to the arises and mature, and they come directly to the mantle zone, where they have to go to the follicular center, where all these kind of changes antigen stimulation, immunoglobulin maturation, somatic hypermutation, all these happen. So mantle cell lymphoma is a mature B cell neoplasm composed of monomorphic small to medium sized cells, mostly irregular nuclear counter, and with a CCND1 translocation, or you can call it cyclin D1 positivity. Okay, neoplastic transform cells like centroblast, paraimmunoblast, and proliferation center. These are completely absent. These are the criteria. They are usually never present. And mantle cell lymphoma approximately accounts around 3 to 10% of all NHL. Again, it is a more of a old age malignancy, like CLL, follicular, mantle is also a old age malignancy. Male to female ratio is little bit male predominant. So what are the most common site apart from your lymph node? Mostly lymph nodal. What are the other side? The gastrointestinal tract. Same with follicular, most common is the lymph node. Extranodal can also present. So here, among all these indolent lymphomas, little bit of this mantle cell lymphoma present as a extranodal presentation, mostly in the GI tract, present as a multiple intestinal polyp. Other area like Waldering, lung, and pleura. What is the translocation I told you in follicular? It is 14-18. So here it is translocation 11-14. So you have to remember 11-14, which occurs between IGH and CCND1. So cyclin D1, you can call IGH and cyclin D1. There it is IGH and BCL2. So these are the very frequent question people used to ask. 14-18 follicular, 11-14 mantle. So in 14-18, what happened? There's BCL2, you get the BCL2 protein expression. Here you get the cyclin D1 expression. So cyclin D1 present more than 95% of the cases. In 5%, that could be cyclin D2, could be cyclin D3, but these are very rare. But SOX11 present in almost all cases, even if it is a cyclin D1 negative. So if somebody asks you SOX11 and cyclin D1, marker for mantle cell lymphoma. 5 and 23 marker for CLL SLL. BCL2, CD10, BCL6 marker for follicular lymphoma. So mantle cell lymphoma, two clinical types. One is indolent. Among these, all these indolent lymphoma, those who have recurrently saying me and Dr. Ganesh, 5. This mantle cell lymphoma little bit erratic. It can be very aggressive. It has never been completely indolent. Okay. So there are two forms. One is clinically indolent, and based upon their, now people are saying indolence present as a leukemic and more aggressive present in case of a nodal. Somebody can ask you how, if it is a leukemia, then it is could be aggressive. No, this is one lymphoma mantle cell where leukemic is indolent but nodals are aggressive. So there are two pathways described. Like this is a naive B cell, mature comes. When it comes to the mantle cell, like in situ follicular neoplasia, here it comes the in situ mantle cell neoplasia. So if somebody asks you, is there any pre-lymphoma condition, like you mostly carcinoma in situ, people must have read in many cancers, carcinoma in situ, where it is confined to the epithelium only, mostly. In lymphoma, there are few pre-lymphomatous condition you can call, like in situ follicular neoplasia, in situ mantle cell neoplasia. In case of CLL, it is monoclonal B cell lymphocytosis. These are the counterpart, you can say, in situ follicular. These are very uncertain potential, may in future, though there is a less chance, yes, in future may transform to a full from lymphomas. Okay, so here it forms a in situ neoplasia. If it is hypermutated immunoglobulin and SOXB, it forms the leukemic non-nodal pathway, and it is mostly little bit indolent. If it goes in this way, unmutated or minimally mutated immunoglobulin, SOXB again be positive. Here SOX11 is negative, here SOX11 is positive, and they come out from the mantle zone, and they comes they present as the extranodal or extranodal mass, and they forms the classical mantle cell. Okay. So here you can see complete effacement of the architecture. You can see the very vague nodules are seen. Again, in the higher power, it is a small cells and with a cleaved nuclei. CD20 positive, BCL2 positive. Again CD20, BCL6 negative, CD10 negative. I told you CD10, BCL6 marker for follicular lymphoma. So there is no follicular lymphoma. Now cyclin D1 is positive. See, so it is a mantle cell lymphoma. So CD5, cyclin D1, mantle cell. Then your CD10, BCL6, follicular. Another case, complete effacement of the architecture, you can see, and very monomorphic regular population of cells, CD20 positive, cyclin D1 diffusely positive. So here what can I show in the last picture, it is some nodular appearance but mantle. Here it is diffuse appearance, again the mantle. So that's why mostly follicular pattern is for follicular lymphoma, but other can present. But you have to do immunophenotyping. In lymphoma, it is very crucial, immunophenotyping and your molecular workup. So diagnosis CD10 BCL6 again negative, again a mantle cell lymphoma. So what happened here? Somatic hypermutation occurs in 20 to 30% of cases, not related to outcome. So and there are many secondary alteration apart from this IGH and CCND1 mutations. What are the poorer outcome? It is more older age, more than 50, blastoid or pleomorphic, Ki67, more than 10%, P53 mutation or deletion. These are associated with poorer prognosis. Actually, Ki67 now they are refined to more than 30% is really required treatment. And in situ mantle cell neoplasia, what happened? It is the pre-neoplastic condition, you find only few neoplastic. Occasional cell, normally it is the normal lymph node. Cyclin D1 completely absent. So in case of mantle cell lymphoma, it is diffuse positive. But if it is only very few thin rim, in case of mantle cell, it is called pre-neoplastic condition and neoplasia. So lymphadenopathy, organomegaly, GI involvement, multiple lymphomatous polyposis. Okay. So this is all about mantle cell lymphoma. So we have 5 minutes. Small lymphocytic lymphoma, same as was Dr. Ganesh extensively covered. So I am not going in details regarding, but if you see in lymph node how they look like, same again. Complete effacement of the architecture. In case you can find some pale zones here, which are called proliferation center. Again, monomorphic nuclei, small cells with rounded nuclei, 20 positive, CD positive. I means these are brown color, which can interpret as a positive. Okay, so CD3 negative, CD5 positive, 23 positive, 5 dim positive. Basically, basically Dr. Ganesh told you this is a T cell marker, but when it aberrantly expressed in B cell, it is a little bit weak. So 5, 23 double positive, it is a CLL. If it present in the peripheral blood, it is sorry, in the lymph node it is SLL. In the peripheral blood involvement, it is CLL. Cyclin D1 negative, 10 BCL6 negative. Clear? So it is a CLL SLL. So these are not required. Okay, immunoglobulin rearrangement is very important. Already Dr. Ganesh discussed, and this 17p 13 deletion, 11q deletion, these are more required for prognostic point of view. So the last lymphoma in the indolent group comes the marginal zone lymphoma. So where it arises from the marginal zone, center of the follicle, follicular, around the follicle, mantle cell. Towards the last, it is the marginal zone lymphoma. So I like, because you people can remember clearly, if I'll show you again that photograph, which make you remember very clearly. See this one. Okay, see here, this is the normal follicle. If anything arises here, it is a follicular lymphoma. Marker again repeating 10 and BCL6. Then comes this dark zone, mantle zone. Marker CD5 23 double positive. Mantle zone CD5 and cyclin D1 with the mantle cell lymphoma. But somehow these CLLs, they arises outside the germinal center, post germinal areas, not the marginal zone. Somehow here it is CD5 and 23. Now come the last one, the marginal zone. It's a marginal zone lymphoma. So marginal zone lymphoma can present as a nodal mass, maybe extranodal mass. So when it's present, the extranodal, where it can present, it can be splenic. So there are basically three, like you can call nodal marginal zone, splenic marginal zone, then comes the mucosa associated tissue, where you can find mucosa, like mostly GI tract, you can find in the bronchial tract. So that's called mucosa associated lymphoid tissue or maltoma. You find in the salivary gland, you find in the thyroid, you find in the, so all these areas you can find a marginal zone lymphoma. Nodal marginal, splenic marginal, and mucosa associated lymphoid tissue. And extranodal lymphoma composed of morphologically heterogeneous small B cell, including marginal zone centrocyte like cells. Okay, also known as monocyted B cell lymphoma, because these cells have a little bit of cytoplasm in comparison to the other lymphomas. So extranodal marginal zone lymphoma or maltoma, mal type, mostly first basically described in the GI tracts or stomach. So in case of maltoma, there is very strong association with infectious etiology. Like in stomach, it is your H. pylori infection. In case of your skin, it is Borrelia burgdorferi. In case of your eye or conjunctiva, it is Chlamydia trachomatis. So in all cases, there is an association with the infectious etiology. Clear? H. pylori, Borrelia burgdorferi, Chlamydia Sikaki. So these are the infectious etiologies. That's why when it involves the GI tract, they usually initial stage they try to treat for H. pylori infection. They give an antibiotic course for H. pylori and before starting chemotherapy. Okay, so how it look like, you can see this is a fragment of the mucosa, GI mucosa, where there is diffuse infiltration by these small size lymphocytes. So what is a classical? It is called lymphoepithelial lesion. So what is mean by lymphoepithelial lesion? See here, okay, so I will show you. So you can see this is one crypt where infiltrated by these lymphocytes. This is another one. So at least 3 lymphocytes infiltrating to the crypt. So it is called lymphoepithelial lesion. So it is a cause destruction of the submucosa with the presence of lymphoepithelial lesion and seeds of small mature lymphocytes. CD20 again positive, CD3 negative. This is a higher part, you can see. So this is a one lymphoepithelial lesion which is very clearly visible. This is a gland which is partially destructed by these lymphocytes. CD5 negative, cyclin D1 negative. So basically in marginal zone lymphoma you find all markers are negative except CD20 because it is a B cell, so CD20 will present, but the disease specific like CD10 BCL6 in follicular, but here it will be absent. CD5, cyclin D1, 23 all absent, or sometimes you may find CD5 or 23 one positivity but not in combination. So this is another bronchial biopsy. You can see this is the bronchial mucosa. It is infiltrated by small size lymphoid cell. CD20 positive. CD43 comes positive in case of, in 50% case of the marginal zone lymphoma. Okay, cyclin D1 negative. So then comes the splenic marginal zone lymphoma. I'll take only more. This is the last slide. After that, only one more. So rare, mostly occur in elderly, present with the splenomegaly in the absence of nodal involvement, or sometimes may find the regional lymph nodes. So usually associated with hepatitis C infection, but it is not. It is a causal association only, but direct transformation of lymphocyte to lymphoma it's not proved. So usually you find patient present with a large splenomegaly, some mainly diagnosed after the splenectomy only. Sometimes it is a spill to the peripheral blood. You can diagnose in the flow cytometry. So median survival is very indolent. Usually at 10 years, splenectomy is considered the optimal therapy. But now there are also many other kinds of therapy has come. Earlier people used to do only splenectomy. Splenic hylar lymph node can be seen, may be involved. As I told, is a regional lymph node. You find a villous lymphocytes in the peripheral blood. So how they look like? You find multiple nodes in the spleen, multiple nodes, back-to-back nodes in the spleen. So large. So when what in the gross, what will find more than 1000 gram nodularity in the gross morphology, coalescence of the white pulp. And in the red pulp, you are not expecting lymphoid follicles, but you expect lymphoid follicles. How they look like here? See, two lymphoid follicles are expanding, merging each other, coalescence of the follicle. Then the expansion of these marginal zones. See, there is a large expansion of the marginal zones. This is a large expansion. If you see in the higher power, this is how they look like. They have a little bit of cytoplasm. Okay, they're positive for CD20. CD5 negative, but sometimes comes positive, CD23 again negative. So these all cover your normal diseases. So one more disease you should know, it is alpha heavy chain disease, all called immunoproliferative small intestinal disease. It is also a type of marginal zone lymphoma only. So like H. pylori induced maltoma, this is another marginal zone lymphoma where problems with the alpha heavy chain, which how they present? They present with the recurrent diarrhea. But if you do what you find again same diffuse infiltration by the small size lymphoid cells. But if you do the molecular analysis, you find there is a truncated heavy chain IgA, immunoglobulin A, which is there is a deletion of this complete heavy chain, and the light chain both are deleted. So on this lymphoplasmacytic lymphoma, it is a chronic lymphoproliferative neoplasm characterized by small b lymphocyte, plasmacytoid lymphocyte. You can say this is somehow related to marginal zone lymphoma with a plasmacytic differentiations. You find many plasma cells here. And when it is associated with your bone marrow IgM gammopathy, it is called Waldenstrom macroglobulinemia. So it is a spectrum, like if you see marginal zone lymphoma, lymphoplasmacytic lymphoma, Waldenstrom macroglobulinemia, they are similar spectrum of diseases, right? So lymphoplasmacytic lymphoma, they look like a marginal zone only with many CD138 positive plasma cells. Waldenstrom is when it's associated with IgM gammopathy. So what you find, due to tumor infiltrates circulating IgM positive cells, hyperviscosity, cryoglobulinemia, cold agglutinin anemia, these are found, and tissue deposition of IgM. And the characteristics is MYD88 L256P mutation. This is very characteristics which find in case of lymphoplasmacytic lymphoma in around 90% of the cases. It can also seen in other lymphomas, but morphologically, if you are thinking of a indolent lymphoma, lymphoplasmacyte, you find MYD88, then it is characteristics. But it can also seen in other aggressive lymphomas. Okay? So in the bone marrow, we find this kind of infiltrate, lymphoplasmacytic infiltrate, we find CD20 and CD138, which indicate the plasma cells. So the nodal marginal zone, same as the counterpart of splenic marginal zone lymphoma, it is a diffuse effacement of the architecture, all markers are negative and small cells. Thank you. Any questions?
Thank you, Dr. Soumya. Any questions to me or Dr. Soumya? You can ask directly or you can post in the chat section.
Don't worry, the first what the initial part which I little bit of speed because there is some problem in initial the broadcasting in the YouTube. I will repeat this normal architecture of the lymph nodes and normal markers in the lymph node in the July in month of June, end of June and July. So don't worry about that. I will repeat everything regarding the normal architecture before the proper lymphoma class. Thank you, Dr. Ganesh. If there is no questions, we can leave. Any questions?
Yeah, I don't. There are no comment section, also no questions. So thank you, Dr. Soumya. I think we'll end the session.
Thank you.
Thank you.